Good morning, everybody. I'm Dr. Dean, one of the registrars from the PMB complex, and my topic for today is advanced cervical cancer, optimizing treatment and outcomes. My supervisor is Dr. Goldman. That's just an outline of our topic for today. In terms of introduction, cervical cancer is the fourth most common cancer in women worldwide. In South Africa, it's the most common cancer-related death. It's the second most common cancer in women of all ages. Women worldwide, more than 85 to 90% occur in resource-limited regions, of which WHO in 2022 showed greater than 94% of cervical cancer deaths occurred in countries with a low human development index. Globally, more than half have regional or distant spread at diagnosis. It's caused by the persistent infection with one of the carcinogenic types of human papilloma virus. Concurrent chemoradiotherapy is the standard of care for patients with locally advanced disease. Palliative treatment is often offered for those with advanced disease. A local study performed showed that even women who are in regular contact with healthcare workers and where screening guidelines exist, 56% of the cases were referred with advanced cervical cancer, and these were women living with HIV. Globally, in 2020, there was an estimated 604,127 cervical cancer cases and 341,831 deaths, with an age standardized incidence of 13.3 cases per 100,000 women and a mortality rate of 7.2 deaths per 100,000 women. Cervical cancer incidence range from 2.2 per 100,000 women in Iraq to 84.6 per 100,000 women in Eswatini. And from mortality rates range from 1 per 100,000 in Switzerland to 55.7 per 100,000 in Eswatini. Substantial geographical and socioeconomic inequalities in cervical cancer globally still exist, and clear gradient of increasing rates for countries with lower levels of human development. This study emphasizes the equitable allocation of resources and access to services as key elements in reducing inequalities in cervical cancer outcomes. In South Africa, the age standardized rate is 35.3 opposed to the global rate of 13.3, and the mortality rate is 19.6 opposed to the global rate of 7.2. And to further highlight to the inequitable resource allocation, 10% of all cervical cancers in Africa is caused by HPV 35, yet it is not part of any of the available vaccines current. The HPV vaccine was introduced in South Africa in 2014, and over 10 years later, we still haven't reached even 50% of coverage. Some of the contributing factors to cervical cancer is the high HIV prevalence rate of 25.8% in South Africa, with that percentage being higher in KZN of 38%. In terms of estimated coverage of cervical cancer screening in South Africa, we are still hovering below the 50% mark. With actual guidelines in place and with more adequate access to healthcare workers and healthcare facilities, we are still missing the boat on the screening. In terms of its histology, squamous cell carcinoma has the biggest range of 70 to 90%, then followed by adenocarcinoma and adenosquamous carcinoma. And you also get some rare subtypes of the histology like neuroendocrine, rhabdomyosarcoma, melanoma, and basaloid. In terms of the definitions, early cervical cancer lesions that are confined to the cervix of the upper 2/3 of the vagina and are less than 4 centimeters in diameter. For locally advanced cervical cancer, these are lesions that are greater than 4 centimeters or that extend beyond the cervix into the surrounding tissue. For advanced metastatic cervical cancer, the disease is characterized by extension beyond the cervix, parametria, and genital structures, involvement of regional or distant lymph nodes, invasion of adjacent organs, presence of distant metastases. When it comes to staging for the advanced local spread, we're starting off stage 3 and stage 3B. That's what our talk will mainly concentrate on today. So 3B is pelvic wall extension with hydronephrosis or a non-functioning kidney. 3C, where there's lymph node involvement, broken down into 3C1, which is pelvic lymph nodes only, or 3C2, para-aortic lymph nodes. Stage 4, which is distant spread. Stage 4A, where there's bladder or rectal mucosa invasion or beyond the true pelvis, or stage 4B, where distant metastases are found, for example, in the lung or the liver. Please refer to the FIGO 2021 cancer report for more further staging detail. For prognosis by stage for the overall 5-year survival, with stage 3B, the 5-year survival rate was 30 to 40%, and 3C1 was 50 to 60%, 3C2 20 to 30%, and with the distant spread, 4A was 15 to 20%, and 4B was less than 15%, which was palliative systemic therapy was preferred. For the diagnostic workup, histological confirmation by a punch biopsy, cone or late biopsy, for clinical examination should be done under anesthesia if resources permit or there's indeterminate clinical exam. Hematological diagnosis would come from the FBC, LFT, renal function, HIV status and control, renal and abdominal and pelvic ultrasounds, chest X-ray, cystoscopy and proctoscopy when indicated. For renal ultrasound, it's important when hydronephrosis is suspected, which can influence the FIGO staging, for example, 3B. For cystoscopy and proctoscopy, those are reserved for cases where there's clinical or radiological suspicion of bladder or rectal invasion. Contrast-enhanced CT of the chest and abdomen, MRI pelvis for local assessment, and a PET CT when contrast-enhanced CT is inconclusive. However, the Uterus 11 trial compared surgical versus imaging staging prior to primary chemoradiation for locally advanced cervical cancer and demonstrated no statistically significant difference in disease-free survival. As we can see, ESGO recommends MRI and contrast-enhanced CT as imaging workup. FIGO does not commit and states that MRI is the best method of radiological assessment of primary tumors greater than 10 millimeters, and that a PET CT is best for nodal disease above 10 millimeters. FIGO further states that areas with a high prevalence of tuberculosis and inflammation, especially in HIV endemic areas, the large lymph nodes are not necessarily metastatic. Clinicians may make the decision on imaging or use fine needle aspiration or biopsy to exclude the metastases. Especially true in advanced stages where surgical assessment of para-aortic lymph nodes may be used to tailor treatment according to extent of disease. Surgical exclusion of para-aortic lymph node involvement has been reported to correlate with prognosis better than radiographic exclusion alone. For ultrasound in cervical cancer, for local staging, it provides assessment of tumor size, echogenicity, and vascularization. It's excellent for parametrial assessment, and the sliding style is very accurate in ruling out bladder and rectal involvement and defining the extent of invasion. A European multi-center trial by Epstein et al. On early-stage cervical cancer, comparable or even better accuracy of ultrasound than MRI in local staging assessment, similarities in the inter-absorber agreement of experienced and less experienced observers, except for parametrial invasion. For regional staging, involves the upper abdomen, we're looking for hydronephrosis or parenchymal metastases. For lymph nodes, it has a high specificity but a low sensitivity when comparable to all other imaging modalities. In this article published in March of this year in the ISWOG journal, the role of ultrasound is emphasized and suggested in resource-limited settings. This was, however, in early-stage cervical cancer, and ultrasounds were performed by expert scanners. The cornerstones of treatment for the advanced cervical cancer. It involves a multidisciplinary team, including a gynecologist, pathologist, expert radiologist, medical and radiation oncologist, and a palliative care specialist. With fertility preservation, it's largely confined to oocyte harvesting or ovarian transposition and surgery. Uterine-preserving techniques are still very experimental. Platinum-based chemotherapy and radiotherapy plays a vital role in the treatment. Novel systemic therapies such as bevacizumab or immune checkpoint inhibitors are fast becoming the standard of care. In an up-to-date healthcare system should be able to provide major advances in imaging modalities, surgical approaches, identification of histopathological risk factors, radiotherapy techniques, and biomarker-driven personalized therapies. So the standard treatment is concurrent cisplatin-containing chemoradiation plus brachytherapy. Is the standard of care for patients with locally advanced cervical cancer or patients who are not candidates for surgery. The concurrent chemoradiotherapy, which is the EBRT, cisplatin weekly, brachytherapy, and if needed, extended field radiotherapy if periaortic nodes are involved. 5 clinical trials demonstrated that concurrent chemoradiation reduced the risk of death by 30 to 50% compared with radiotherapy alone. A subsequent Cochrane meta-analysis reported a 19% relative reduction in risk of death with chemoradiotherapy compared with radiotherapy alone, which translates into an absolute survival benefit of 6% from 60 to 66% at 5 years. For stages 1B3 and 2A2, concerning neoadjuvant chemoradiotherapy and radical surgery, it is actually very controversial. Concomitant radiotherapy remains the standard of care for locally advanced cervical cancer. Radical surgery after neoadjuvant chemotherapy may yield non-inferior overall survival outcomes with acceptable toxicity and health-related quality of life in selected patients with following scenarios. Young patients who decline radiotherapy for concerns about possible radiotherapy-induced toxicity and want to preserve overall quality of life and sexual function. Poor availability and/or accessibility to adequate radiotherapy facilities, especially in low-income countries. Contraindications to radiotherapy. To avoid the combination of radical surgery and post-operative radiotherapy, decision-making regarding adjuvant management after radical surgery should not be rigorously based on traditional selection criteria for adjuvant treatment, but should be individualized. In the EORTC phase 3 randomized control trial, it showed that neoadjuvant chemo is not superior to concurrent chemoradiotherapy, and that concurrent chemoradiotherapy remains the standard of care in the setting. Gupta et al., a single-center phase 3 randomized control trial, showed cisplatin-based CCRT showed superior disease-free survival compared with neoadjuvant chemo as for patients with locally advanced cervical cancer. Periaortic lymph nodes. Historically, it has been widely debated whether periaortic lymphadenectomy provides a therapeutic benefit or has a diagnostic role. The role of lymphadenectomy has been strongly challenged by recent evidence. The prospective multi-center randomized Uterus 11 trial compared surgical versus imaging staging prior to primary chemoradiation for locally advanced cervical cancer and demonstrated no statistical significant difference in disease-free survival between the two groups after a median follow-up of 90 months. Therefore, systemic periaortic lymphadenectomy should not be recommended. The Parola trial is assessing whether periaortic surgical staging followed by chemoradiation improves disease-free survival compared with radiologic PET-CT staging alone in patients with stage 3C1 cervical cancer. However, it should be noted that requiring preoperative PET-CT staging for every patient may limit applicability to the real-world setting. PET-CT imaging is not available in 95% of low-income countries and 92% of lower middle-income countries. Therefore, treatment standards may vary across countries depending on available resources. Treatment and management of the periaortic lymph nodes can improve survival and quality of life. The management depends on extent of metastatic disease, prior treatment history, and a performance statement. The systemic therapy is the first line is preferred regimens from the COG240 regimen, which is the cisplatin, paclitaxel, bevacizumab. However, bevacizumab benefit improved survival by 17 months. However, it did increase the risk of fistulas and thromboembolism. Pembrolizumab and chemotherapy, as per the Keynote 826 trial, improved overall survivals by 24 months versus 16 months with chemo alone. For periaortic lymph nodes only that are non-bulky, extended field chemoradiation plus brachytherapy boost is recommended with a 5-year survival of 30 to 50% if there are no other distant meds. Other options for stage 4A treatment is, regardless of the trend, brachytherapy, although resource intensive and not available in all settings, should be considered an essential component of the standard of care for patients. And recent advances in image-guided brachytherapy should make new options available to patients. There is no evidence that adjuvant chemotherapy has benefit after completion of primary chemoradiation, as demonstrated in the recent Outback trial. However, the Keynote A18 trial included patients with high-risk locally advanced cervical cancer, stage 1B2 to 2B, and stage 3 to 4A disease. Patients in the experimental arm received pembrolizumab with chemotherapy, followed by pembrolizumab intravenously every 6 weeks until disease progression or for up to 24 months. The primary endpoints were progression-free survival and overall survival. Compared with chemoradiation alone, the addition of pembrolizumab demonstrated a statistically significant improvement in 24-month progression-free survival in the overall population. The exploratory subgroup analysis showed that the benefit was primarily attributed to patients with a FIGO stage 3 to 4A disease. As a result, the FDA approved pembrolizumab with chemotherapy only for patients with FIGO stage 3 to 4A cervical cancer. When it comes to pelvic exenteration, the treatment for loco-regional relapse depends on whether the patient has had previous radiotherapy. Previously irradiated patients should be considered for surgery. Pelvic exenteration is generally indicated as the last therapeutic option for patients with advanced, persistent, or recurrent cervical cancer and should be considered as individualized approach after careful patient selection and counseling by a multidisciplinary team in a specialized center. It is generally recommended for central pelvic recurrence in the absence of pelvic sidewall involvement, extrapelvic nodes, or peritoneal disease. Extended pelvic surgery, laterally extended endopelvic resection, intraoperative radiotherapy can also be considered in carefully selected cases with pelvic sidewall involvement. In the era of targeted therapies, systemic therapy could be considered before and or after surgery for local regional recurrence. For patients who wish to avoid pelvic exenteration, systemic treatment alone remains a viable option, especially in the bevacizumab immunotherapy naive setting. For salvage surgery, individualized re-irradiation with external beam radiotherapy plus minus chemotherapy can also be considered an alternative to surgical resection for local regional relapse after primary radiotherapy. Radiotherapy naive patients and those with outside field relapses should be treated with external beam radiotherapy plus minus chemotherapy. Surgical resection plus minus intraoperative chemotherapy is another option. Brachytherapy might be considered for small superficial vaginal relapses. For highly selected patients with isolated distant metastases, such as nodal, lung, liver, or bone, even to local therapy, should use combined local regional treatment modalities, including surgery, external beam radiotherapy, plus minus concurrent chemotherapy, and or local ablative therapies might be considered, possibly followed by adjuvant systemic therapy. Systemic therapy. Local regional therapies may be combined with systemic therapy, such as pelvic radiotherapy in case of complete response of distant metastases with response or stability of pelvic disease, or surgical resection or radiotherapy for residual extrapelvic oligometastatic disease. Immunotherapy has demonstrated activity not only in the management of metastatic, persistent, and recurrent cervical cancer, but most recently in locally advanced cases. While the addition of durvalumab to chemoradiation therapy for locally advanced cervical cancer did not provide a survival benefit in the randomized phase 3 CALA trial, the results of the randomized phase 3 Keynote A18 trial, however, demonstrated the efficacy and safety of pembrolizumab versus the placebo in combination with concurrent chemotherapy. As a result, the FDA approved pembrolizumab with chemoradiotherapy. Immunotherapy may have a promising role earlier in the treatment paradigm of cervical cancer. The combination of neoadjuvant chemoimmunotherapy with surgery holds potential as a novel therapeutic approach for locally advanced cancers. The phase 3 randomized control trial with GOG-240 demonstrated that the addition of bevacizumab to combination chemotherapy in patients with recurrent, persistent, or metastatic cervical cancer was associated with an improvement of 3.7 months in the median overall survival. In the phase 3 randomized Keynote 826 trial, progression-free and overall survival were significantly longer with pembrolizumab than with placebo among patients with persistent recurrent or metastatic cervical cancer who were also receiving chemotherapy with or without bevacizumab. The FDA approved the addition of pembrolizumab for tumors with PD-L1 combined positive score of greater than or equal to 1. For metastatic, persistent, or distant recurrent cervical cancer, based on the practice-changing results from the GOG-240 and the Keynote E26 trials, platinum-based chemotherapy is the current first-line treatment of choice, plus minus bevacizumab, plus minus pembrolizumab. The phase 3 randomized GOG trial demonstrated that there was an improvement of 3.7 months in the median overall survival. And the Keynote 826 trial found that among patients with persistent recurrent or metastatic cervical cancer who were also receiving chemotherapy, there was no benefit that was found for tumors that were not expressing the PD-L1. So the FDA approved the addition of pembrolizumab for those tumors. The BEAT-CC trial showed that the anti-PD-L1 immune checkpoint inhibitor atezolizumab significantly improved progression-free and overall survival when combined with standard platinum-based chemotherapy plus bevacizumab, paving the way for another practice-changing strategy in this setting. For second-line treatment, should include the immunotherapy if not previously administered. The phase 3 randomized EMPOWER cervical trial demonstrated that cemiplimab significantly improves overall survival compared with single-agent chemotherapy in patients with recurrent cervical cancer after first-line platinum-containing chemotherapy, regardless of the PD-L1 status. In addition, the Keynote 158 basket study showed that pembrolizumab monotherapy provides durable anti-tumor activity and manageable safety in patients with advanced PD-L1 positive cervical cancer who experienced progression during or after chemotherapy. For the recurrent cervical cancer amenable to local treatment, in terms of local regional disease prior to radiotherapy or radiation therapy naive, or the oligometastatic disease, pelvic extenuation, re-irradiation, or systemic therapy, and for the RT naive, EBRT, BRT alone, surgical resection, and the systemic therapy. For oligometastatic disease, resection, EBRT, and adjuvic systemic therapy. We did go through this slide a little more in detail in slides 35 and 36. Palliative care is crucial for patients with 4B or recurrent cervical cancer, focusing on symptom control, psychosocial support, and maintaining quality of life. Early integration at diagnosis of advanced disease improves outcomes, decreases hospitalizations, and increased survival in some studies. Multidisciplinary team is essential. For management of symptoms, most important is pain control, of which you may use the WHO analgesic ladder and should be adjusted accordingly. As for mild pain, non-steroidal anti-inflammatories, and for severe pain, stronger opioids. Management of the patient's anemia, infections, fistula, psychosocial, and nutritional value should be taken. Bleeding and vaginal discharge, palliative radiotherapy for tumor bleeding may be offered, and tranexamic acid. For malignant bowel obstruction, osteotype reduced secretions, stenting or colostomy. For urethral obstructions, nephrostomy or urethral stenting. For lymphedema, compression gromments, manual drainage, and or physiotherapy. End of life care, where estimated prognosis is less than 6 months, should be initiated early, and focus should be on comfort, terminal sedation, subcut or IV opioids, and anticholinergics, and when needed. Oncologic follow-up aims to detect recurrence and or secondary cancers, monitor the quality of life, manage long-term sequelae, and provide holistic supportive care. Only 26 to 36% of recurrences are diagnosed during routine follow-up, while the majority of recurrences are symptomatic. A reasonable approach for patients with cervical cancer who have had complete response after primary treatment includes clinical re-evaluation every 3 to 6 months for the first 2 years, every 6 to 12 months or another 3 to 5 years, then annually. Up to 45 to 50% of relapses are localized within the pelvis. Therefore, physical examination is crucial for cervical cancer surveillance. Cervical vaginal cytology tests are not recommended because of the low risk detection rates, 0 to 17%, and the risk of false positive results after radiotherapy. Patients living with cervical cancer or the sequelae of cervical cancer treatment deal with a host of physical, emotional, and social issues unique to the more survivorship issues or social issues unique to the disease, and younger age at diagnosis leads to more survivorship issues over time. The physical sequelae of locally advanced cervical cancer are particularly linked to social isolation and depression. Bladder and bowel dysfunction is another potential long-term effect of radiation therapy, which can negatively affect the quality of life. Oncologists should be cognizant of psychological barriers to sexual well-being, such as decreased sexual interest, anxiety about sexual activity, and provide appropriate support. Patients are also at risk for mood disturbances such as dysphoria and anxiety, of which anxiety has been a well-described phenomenon in oncology. Furthermore, patients with cervical cancer face the stigma of having a preventable cancer caused by a sexually transmitted disease. Ethics that are involved. Autonomy, informed consent, and health literacy. Autonomy must understand their diagnosis, prognosis, and treatment options to make informed choices. We want to concentrate more on the justice and distributive justice when it comes to ethics for cervical cancer. Every woman, regardless of geographic or economic status, should have equitable access to evidence-based care. Prioritizing resource allocation fairly and ensuring rural and poor populations are not neglected. When it comes to equity and access to care, the challenge is there's limited access to diagnostic tools, example, MRI or PET scans, and treatments such as radiotherapy, chemotherapy, and immunotherapy and palliative care. That creates a gap in this care. When it comes to resource allocation and priority settings, the challenge is there's scarce resources, example, few radiotherapy machines, which may lead to delays or rationing. The ethical concerns are utility and fairness, where decisions must balance the greatest good for the most people with fairness to all individuals. The implication is a transparent ethical framework should guide positive triage decisions. Another issue to think of is where the patient is for palliative versus curative intent. Another one is stigma and psychological harm, where cervical cancer may be associated with stigma due to its link with HPV and sexual activity. With the ethics concept of beneficence, addressing psychological, social, and spiritual needs, and psychological support and community education is needed to reduce the stigma. This is a case scenario. A 32-year-old mother of two who is the sole breadwinner was diagnosed with the stage 4A cervical cancer, who has hydronephrosis with good cortical thickness post-curative CCRT. Now incontinence is hampering her quality of life and her ability to work. The VVF is not amenable to surgical closure. So the treatment option for her would be urinary diversion to preserve the renal function, quality of life, and her ability to work, even though her 5-year survival for stage 4A is 15 to 20%. Distributive justice plays a major role in our setting, where the clinician is often faced with choosing between this case and a low-risk, surgically curable cervical cancer to utilize the limited theater time available to us. For the second scenario, a 32-year-old mother of two was the sole breadwinner, diagnosed with the stage 3C1R cervical cancer. CCRT was offered to her, and she had persistent disease after the treatment. What would be her treatment option for this case? Because of distributive justice and the lack of immunotherapy and access to clinical trials, it often mandates that the best option we can offer this patient is to offer best supportive care. Cancer care in all types in South Africa can range between 10,000 Rand and 1 million Rand per patient per year, depending on complexity. Recent data shows chemotherapy alone averages about 15,774 Rand in the public sector per patient per treatment episode. Stage 4 cervical cancer treatment in the private sector can average around 522,000 And for early stages, average costs were approximated at 352,500. Those are just some of the estimated costs for the immunotherapy drugs in South Africa, where the pembrolizumab actually works out to an average cost of about 166,000 for one dose. This high cost burden is something that needs to be considered, especially when looking at costs for screening and vaccine rollouts. In the bigger picture, it would cost less to prevent than to treat these advanced stage diseases. For future direction, the pipeline of the novel biomarker-driven targeted treatments is consistently evolving, and more treatment options are expected to be available in the near future. Immune checkpoint inhibitors and antibody drug conjugates are the cornerstone of this new era of precision oncology in cervical cancer. Some of the other later treatments to look out for is tumor-infiltrating lymphocytes, autologous tumor-infiltrating lymphocyte therapy, targeting epidermal growth factor receptor, targeting angiogenesis. Angiogenesis inhibition has been investigated due to the central role of angiogenesis in cervical cancer carcinogenesis and the disease progression. Targeting the mTOR pathway and ribonucleotide reductase inhibitors. Also to look out for AI for determining the recurrent risk. The World Health Organization 90-70-90 targets are part of the World Health Organization's global strategy to eliminate cervical cancer as a public health problem. It was launched in November 2020. These targets are set to be achieved by 2030, forming the foundation for elimination strategies. What it breaks down to is 90% of girls to be fully vaccinated with HPV vaccine by age 15, 70% of women screened using a high-performance test by age 35, and again by age 45, and 90% of women identified with cervical disease receive appropriate treatment. The goal of the strategy is to bring the cervical cancer incidence below 4 cases per 100,000 women, so the threshold for elimination as a public health problem. As shown earlier in our slides, South Africa is far behind on these numbers. In terms of screening and or receiving the vaccines, we are less than 50%. And in terms of receiving appropriate treatment, we still got a long way to go. However, there is hope. Kenchi and Doris were studies that were done in Africa, comparing a single dose bivalent or non-avalent HPV vaccine in girls and women from 9 to 20 years of age with 2 or 3 dose regimens. They found non-inferiority. Immunogenicity and immunobridging analysis of these participants found that a single dose of HPV vaccine, when given to girls in the target age range for vaccination, induces immunity responses that could be effective against persistent HPV 16 and 18 infections at least 2 years after vaccination. This gives countries like ours hope, but we still need to vaccinate more than we currently are. For all comers of cervical cancer, a 5-year overall survival is around 67%. The prognosis of early stage disease is significantly better than later stages, with a 5-year overall survival rate of greater than 80 to 90% for early stages, 60% for locally advanced cancer, 30 to 35% in cases of positive local regional lymph nodes, and less than 20% for distant metastatic disease. Approximately 1/3 of women with cervical cancer experience a recurrence during follow-up, with most relapses occurring within the first 2 to 3 years after treatment. So in conclusion, While international efforts aim to eliminate cervical cancer as a global health problem by promoting widespread access to prevention and screening, recent years have seen major advances in the treatment of cervical cancer, including sophisticated imaging modalities, less radical surgical approaches, improved molecular diagnostics, modern radiotherapy techniques, and biomarker-driven personalized therapies. These achievements have led to a new era in the management of cervical cancer. Tailoring surgical and radiation approaches to early-stage cervical cancer allows for optimization of oncologic outcomes while reducing morbidity and toxicity in patients who are often young and for whom preserving quality of life and desire for childbearing is essential. The advent of immunotherapy has dramatically improved the prognosis of patients with advanced and recurrent cervical cancer, and additional novel agents, such as antibody-drug conjugates, are expected to further enrich treatment options. Cervical cancer is the only cancer that we know the exact natural history and the progression of. We can detect and screen it for years before it advances. We have the vaccines and can vaccinate against it, yet we need to be talking about managing advanced cervical cancer. At present, we are not in this fight against cervical cancer. We are watching the war from the sidelines. Thank you.
Thank you so much, Dr. Dean, and well done putting that into the time frame. I think our talk highlights the vast burden that we have of advanced CA cervix in countries like ours. And we mustn't be fooled to think it's only in the public sector. In the private sector, I would probably say that the numbers are very similar. Patients present with advanced CA cervix more than they do with early stage CA cervix. I saw a lady who's 72 years old on Tuesday, and she had never ever had a cervical cancer screening in her whole life. And that is in the private sector. So with September being our National Cervical Cancer Awareness Month in South Africa, I think what we want to hone into everyone in the audience and everyone that you know basically is you should sound like a broken record. Every woman that you meet, you should ask them if they've had a cervical cancer screening. And every child or every woman with a child, everyone with nieces, you should ask whether or not they've been vaccinated against HPV. They must at some point actually start thinking that you are being funded by the HPV vaccine companies, because it's the only way that actually we will be able to beat this. We shouldn't be talking about advanced CA cervix and the management of it. The first world is generations above or ahead of us in terms of immunotherapy. And yes, you talk about 3 or 6 month survivals as opposed to the standard, prolonging the survival by adding a 1.6 million rand course of pembrolizumab. But we're really talking about distributive justice and spending that sort of money when we can just prevent these women from getting advanced CA cervix. I think should be the crux of our talk. I'll open the floor up for any questions or comments. Dr. Dean, once again, well done. I know the immunotherapy words are difficult to pronounce. You did well. Are there any questions from the floor?
Thank you.
Good morning, Dr. Bhatt and Dr. Dean. I do not see any hands for now, but once again, thank you so much for presenting this topic and bringing it back in to context as to where we are with advanced disease, because quite a lot of emphasis obviously is in prevention at early stages. And we understand because most of what you spoke about, I think, belongs to the gynae onco team. But thanks for that. As you said, he kept to the time and covered all the pertinent parts. I appreciated the advances in firstly in the latest staging that didn't include the C's when it comes to 3 in the olden days, and now we've got a C and different types of C in 3B. I mean in stage 3. I wanted just to comment about if you could just summarize maybe the treatment, not what we offer now. And I saw your case report, I mean your case presentation, that someone with a 3C1 would just be for palliative. In the olden days, 3B and forward, 4A and what have you, was for what we called palliative radiotherapy, and that would involve, I think, just the brachy and so forth. But I often get an understanding that our registrars do not have a full depth of what is brachytherapy, teletherapy, what it involves. Do they actually, at some point, we were lucky in our days that we would rotate, even if it was just for one day, to go and see these machines, understand what is teletherapy, brachytherapy, what they mean by this point, that point. Do they still use those things? And I think it's good exposure for registrars, so that when they speak about how advanced cervical cancer is managed, even just the radiotherapy, the overall regimen that is involved, radiotherapy and so forth, that understanding is lacking with our registrars. Maybe one of the faults is that we've compartmentalized this too much, to the point that we left it to the hands of the generalist, and the generalist has no understanding of it entails. So I just wanted your comment on that, about just that basic understanding of chemoradiotherapy and the different components thereof, and what we can offer now. I heard you saying that it's all palliative, but what would that look like in our setting? That's the one point. And yeah, just to appreciate that. And then one about comment about our attempts towards enhancing or increasing our outreach, uptake rather, for cervical cancer screening. I think as a province, and I agree that generally we are doing very badly as a country. The leading province is KZN, and we've got good reasons for that. We work well with the teams and so forth. It doesn't mean that we are even closer to 50%, but at least we are trying. And just to highlight that there is a drive, and I hear you saying cervical cancer awareness month is in September. Now in August, there has been a call from the MEC and the DG. Is it called the DG, Head of Health? That every district should try and reach a minimum of 1,000 women in their various campaigns for cervical cancer screening. The Durban one will take place on the 30th. It was meant for the 23rd, but it's the 30th, and we're calling for all the volunteers, all hands on deck. But I would say the same to all the other districts, including obviously Maritzburg, where you are presenting from. Please find out from your local, or maybe Dr. Moreni, if he's in the audience, he will indicate where the activations are taking place. It's really just to highlight and make sure that everybody is on board when it comes to HPV screening as a mode of screening. Yeah, so basically that was that, but I had a question earlier on. Thanks.
Thank you so much, Prof. Yeah, Dr. Dean has asked that I answer the question, which highlights your point. I think our registrars rotate through our MDT clinics and our medical and radiation oncology clinics, but they're more involved in the I want to say the staging aspect of it, not necessarily the going to see the treatment and see what is brachytherapy and what is EBRT. So I probably don't blame them for not knowing, how it works, but it's very valid what you're saying. Every gynecologist should know the principles of it, and also how it affects the woman's quality of life, because it has a severe morbidious sequelae. So for CA cervix stage 3, C1, which is the case scenario we used, which is pelvic lymph nodes, the standard of care would be concurrent chemoradiotherapy, and that would be with curative intent. The scenario we referred to was someone who had persistent disease after a CCRT, and them in our setting we relegate to palliative care. But the standard of care, like I said, is concurrent chemoradiotherapy, and that means that they get a platinum-based chemotherapy with the radiotherapy as a radiotherapy sensitizing agent. So this involves external beam radiotherapy and also brachytherapy. So the external beam radiotherapy is, the patient is on the bed and the machine is giving the radiotherapy from above. And that's probably a talk on its own in terms of how you could adjust your radiotherapy to minimize damage to the surrounding tissues, because we must remember that and the bladder. So these women, invariably, almost all of them end up with either a radiation proctitis for life or a radiation cystitis. Then they also include 3 sessions of brachytherapy, which is there's different modalities of doing that, but in our settings, what we are using is just intravaginal brachytherapy as opposed to intracavity brachytherapy. So it's like a cylinder that is put, and it's almost, if you want to imagine a transvaginal probe, it's touching the cervix, and the radiotherapy is then applied directly to the cervix and the parametrium in that tissue. And this unfortunately leads to significant vaginal stenosis in women. So if you have a young woman who is relegated to this standard of care, which is curative, she will definitely end up with some form of sexual dysfunction because of this vaginal stenosis. And the majority that we encounter actually don't have any more vaginal penetrative sex because of the severe stenosis that they get. And then from the EBRT, the complications, like I said, cystitis and proctitis is quite significant. We must also realize it's a long course. It's a 6-week treatment course, because we give them small fractions at a time. So they go in every day to get a dose of 3 grades per day times 30, for example, or times how many other days. It depends on the total dose that is calculated by the radiotherapist or by the technicians and the doctors who work out, and that is dependent on the tumor size. And like you said, Prof, I think when you are exposed to those units, you start to know what is point A and how do they work out the doses, how do they target the doses to the specific tumor and where the most tumor burden is. And then you realize how the scatter radiation actually affects the adjacent organs. And it just highlights more and more why we need to treat CA cervix, like you're saying, early on, because then you avert those complications. They don't happen then. I hope that answers your question.
Yeah, if I can just with that, thanks for that. And for someone who has never seen what you're talking about, it's really French. So I would appeal to the trainers, you, Dr. Atisha, Dr. Makatini, please allow the registrars, if it's just one day when they are doing oncology, to go spend time with the radiotherapy people. It helps with understanding. And I think you cannot be a gynecologist and counsel a patient properly if you really do not know what people are talking about. It really makes sense. And we are not asking for a long 2-week rotation or anything. You just have to see those machines, see the insertions of those probes and whatnot. So I still think there is value in having seen and being part of radiotherapy treatment or planning, and not just theoretical staging or something like that. Yeah, thanks for
absolutely, that. Absolutely. I agree with that. It's something we should definitely do. Okay, thank you so much, Prof, for that and for the comments. Are there any other comments on the floor? I can't see any other hands. It is payday today and there's rugby this weekend. Are we happy if we...
Okay, before payday, we've got someone here in our midst. We've got Antia from MSD, and she's just going to say a few words to the audience. Again, reminding you, I can see Queen 90 people are here about the campaigns that are going on in every district. Please find out from your local district office when the date is and encourage the local doctors to participate. The Durban meeting is on the 30th. We're calling for all volunteers. It's at Pixley Gaseme Hospital from 7 o'clock on the 30th. All right, over to you, Anthea. Thanks. And thank you, Button team.